So many of the things I'm going to talk about have already been mentioned, so which is good. This 1/3 of all the patients we meet with a newly diagnosed cancer are brain tumors, having a tumor in the central nervous system, and they do well, more than 80% overall survival. But so they are a growing group of young adults, and sometimes not so young adults nowadays, amongst us. But they have, sorry for the typo, late complications, previously called late effects. The field is gradually shifting from the term late effects to late complications. The complications are cognitive, which is the theme of this symposium, motor function, hormonal dysfunctions, and many others. This is a quote from Ingrid Emanuelsson, who worked at the Region Habilitation in Gothenburg. It's a quote from Barncancerfonden, actually. They used, "We saved their lives, but we failed to help them afterwards." And this is where pediatric oncology is. Globally, at least in developed countries that can afford all the treatments. Having a brain tumor is by definition having an acquired brain injury, partly because the tumor affects the normal tissue, more or less, just by being there. It may cause hydrocephalus, high pressure in the brain. If that lasts for an extended period of time, that will cause brain injuries. The surgery, removing as much as you safely can, is by definition a traumatic brain injury. Chemotherapy affects cognitive function in ways that we don't completely understand, and radiotherapy is perhaps the most well described factor in this context. Now I have from Anna Embring's presentation. I will update this with a newer reference. Thank you. IQ drops over a decade, maybe as much as 30 points. If you're older or younger when at the time of diagnosis, that makes a difference. And in references, we often see that 50 to 97% of all the patients treated with cranial radiotherapy will experience these late complications. I would say that it's closer to 97. If you look hard enough, you will find things. But there is a huge variation. When I see these patients in the hospital, some have done very well. They only have reduced processing speed. Otherwise, they do quite well, whereas others suffer much more. The risk factors are age, low age at diagnosis, the dose, the radiation dose, the presence or not of hydrocephalus and how long it lasted, and intrathecal chemotherapy. These are major risk factors. So what happens when we irradiate a young, still growing brain? We and others have looked at this in animal models and found that many things happen, of course, in the brain, but particularly cells that proliferate under normal circumstances. And those are very few in the brain. Of course, if you have a cancer, the cancer cells proliferate. That's why the radiotherapy works. But we also have neural stem and progenitor cells that produce new neurons lifelong in the hippocampus. And these proliferate under normal circumstances. And if you subject them to a moderate dose of radiation, they disappear, just like the cancer cells. And this seems to be long-lasting. And this affects memory and learning function, at least in rodents. Is it the same in humans? Well, this elegant study by Jonas Frisén showed that using carbon-14 dating from the nuclear bomb tests during the 50s, that we get on a daily basis 1,400 new nerve cells in our hippocampi, so 700 per side, and this happens throughout life. And it does seem like on autopsy studies that patients who have been treated with radiochemotherapy do have lower levels of proliferating neural stem and progenitor cells. So this is one aspect of many cellular systems that are affected in the brain by radiotherapy. So what can we do? Proton radiotherapy has already been mentioned. Having the possibility to delineate much more clearly areas that you do not want to irradiate. Physical exercise has been touched upon. There are pharmacological agents that might be used, some of which have been mentioned. Proton radiotherapy, Anna showed very nicely that the delineation to areas that you do not want to irradiate can be very sharp. And some studies are emerging indicating that there may be differences. This study from Lisa Kahali showed that there were slightly better cognitive outcomes after proton compared with photon therapy. But the differences are small and there is a great need for more studies. And of course there are no randomized controlled studies that I'm aware of, because the field shifted. When protons became available, all the kids get the proton therapy because it's assumed, for good reasons, that it would be better. So these randomized control studies are still lacking, and the studies that are performed compare patients from centers where proton therapy is available with centers where it is not. This study is a study from Gothenburg, where they estimated the effect of intensity modulated proton therapy, rotating the proton beam around the patient, protecting the hippocampus and the neural stem progenitor cells. You would, I do not show this picture, but they estimated a significant protection of cognitive outcome. But this remains to be proven also in a clinical setting. Physical exercise is good. It increases neural stem and progenitor production in the hippocampus. This is well known. It's good for many things in the body. In Gothenburg, Magnus Sabel and co-workers used video game consoles to make children and adolescents who had been treated with radiotherapy exercise using these game consoles in a way that is fun. They were asked to do this for a number of weeks or wait, and then there was a crossover design. And even though it was a small pilot study, the physiotherapist that tested them found a significant improvement in body coordination. A second study looked at the activities of daily living using an AMPS test, and there was a clear, significantly improved function in terms of activities of daily living. There was no significant difference in terms of memory and learning, unfortunately, which we were perhaps most interested in. But again, it was a pilot study. Our friends in Toronto, at about the same time, performed a group therapy, group intervention, with 12 weeks of training, 3 times 90 minutes per week, and found that the children and young adults who had trained, they had increased white matter, increased hippocampal volumes, and reduced reaction time. So physical exercise is good. We just have to learn when to use it, how to dose it, and how to maintain it. This is a initiative with an exercise intervention during therapy that I believe Aron and many others know much more about than I do. A European initiative. This is a protocol published from St. Jude where they have designed a randomized telehealth-based intervention to improve fitness in survivors. This is unlike the previous one, which is during therapy. This is at least 5 years after the end of treatment. They want to include 160 patients to a 20-week intervention or not. So, what about pharmacological agents? There are a few studies, drug trials, to alleviate cognitive decline after cranial radiotherapy in children. At St. Jude, they have memantine studies, an Alzheimer's disease drug that was mentioned earlier. They have preliminary data that they do see some effects, reported at the ISPNO meeting in Philadelphia this year. Metformin was also mentioned, a type 2 diabetes drug. Susanna mentioned it as having both protective effects on the brain as well as possible anti-tumor effects. Lithium, a study that is open in Sweden and soon to open also in Denmark. Lithium has, at least in animal studies, very impressive protective effects on the brain and also equally impressive anti-tumor effects. I also learned recently that there is an active methylphenidate study open in Denmark. I'm not sure if it's also open in Lund or only Denmark. It's of course to counteract the fatigue and attention deficits, which secondary may also improve cognitive outcomes. So there are not so many, but there are studies that are ongoing. None have been completed yet. So the possible treatments and strategies that we see now include proton therapy, physical exercise, drugs, and hopefully other strategies and preventions that I hope or I envision that we can use these in combinations in a way that we treat the complications in the same way that we have treated the disease, possibly starting at the same time and having protocols that go beyond the end of treatment of the actual disease. And how do we do this? Carlos in the group, who's in the audience, he said to me in a meeting, we should give the complications diagnosis numbers, because then they will be diseases just like all the other diseases, and then we will treat them. It will be part of the routine. It will be part of there will be resources allocated. So we bounce this idea on you. What do you think? How shall we make this happen? How shall we make this part of the whole treatment? We envision treatment protocols that continue beyond the cancer, long after the cancer is gone, to take care of what we have the damage caused. So, well, I would wish for a second silent revolution I used the Swedish quote here because it sounds better than an English translation from Barncancerfonden. Att leva, inte bara överleva. To live, not just survive. So what I would like to see, or we, is to see the quality of survival, quality of life increase just the way the overall survival has developed the last decades. Thank you.
Thank you so much. Questions?
Thank you very much, Klas. Very interesting. Just to comment on the diagnosis. So the Swedish Working Group for Late Effects have been working for some time now together with UFM Sverige, the Late Effects follow-up clinics for adults after childhood cancer, on trying to define diagnosis of late effects and
wonderful.
to make it so all centers use the same. So if that's something that you would like to get involved in, you're more than welcome.
Thank you.
Hello, I must thank you for a good lecture. I was thinking, I really like the idea of putting a label or tag, because if we do talk about a diagnosis, then we can also advantage from other fields having knowledge within the same. I was thinking when you were talking about pharmacological treatments to alleviate late effects, do you know if there's any study that where they look at medication that they use to prevent migraine attacks? I'm thinking because a lot of youths are telling me about headaches and their reoccurring risk factor being a woman. We know that chronic migraine is also many times connected to hormones, and a lot of people are having much better lives with this preventive medication when it comes to chronic migraine. Is this something that they have tried also with pediatric cancer survivors?
Do you mean the nasal?
No, not at all. Not
administrated
at all. I'm talking
migraine?
about beta blockers. That's actually like metoprolol that you are using continuously, and this is a very good effect when it comes to chronic migraine to prevent headaches.
Very good question. I don't know. Does anyone else in the audience know?
Yes. Interesting hypothesis, right?
Yeah.
More questions? No more questions, everybody. So we thank you a lot, Klas.